and I'm going to welcome everyone. Patty, you will watch the chat box, but let me first say that chat box is great, except this idea of a mastermind is that we all have an opportunity to talk and share with each other and learn from each other. And so I want to invite, if you have a comment to make, if you want to talk about something, put it in the chat box. But if I see it, I'm going to go say that out loud, because it is all about sharing with each other. So this is our fifth mastermind from the Dental Codologist Members Network community. And I appreciate you all being here. We did have an exciting time in Chicago. We had our first meetup. One of the benefits of membership is to get together and get to know each other. And we had an amazing turnout at our first one. I think we ended up with, Patty, a total of 73, 75 people that came to our very first meetup at CDS. So we have a few pictures I want to thank everybody that got involved, that helped, that I ended up giving you a job on the fly, as well as Carol Roselle and Kim Jockheim were our assigned. They were asked to take pictures, but Jeanette Miranda and some of the other people that also volunteered and stepped up. Again, we had a great turnout. We had everybody from, there's Lisa, see, look at pictures, Lisa and Jeanette up there on the upper left. We have some of our corporate friends, including Karen and Debbie Z, Patty with her new jacket. Isn't that an awesome jacket Patty got on? You all like that one? Then we had, this is Brian Donahue. He's one of the many press people. We had 6 different people from the press that came, as well as our wonderful sponsors. This is Brant Herman from Mouthwatch, and the other wonderful sponsor was Cindy Purdy with Dental Works. So it's all about getting together, and it's all about us getting together to become a think tank. Now, that's a term we hadn't thought of before, but I think Linda Jorgensen, I think you get a credit for our discussion the other night when we were talking about it, because the idea that we come together to have a voice in coding and in the health of future. And that's why I want to thank all of you Think Tank DCM members. Now, these names are the names that I'm going to call out, and I'm going to have you identify yourself. And these are the ones that said yes and confirmed on the through the Evite. If I don't say your name at the end, I want to make sure to recognize you. So Sherry Lukes, are you here yet? Not yet. Maureen House, say hi, Maureen.
I'm here with laryngitis.
Great to hear from you. By the way, I've changed a part of my CDT 2018 book because of our discussion about implants. You'll hear more about that at another time, but thank you for even asking that question. Lisa.
Hi, I'm here.
Great.
Hello, everyone.
Welcome. Lisa is also a member of our Academic Advisory Committee, which I'll be talking about in a little bit. Terry, are you here yet? Not yet. I know people have also said they'll come in when they can after work and after other meetings, etc. Vicki, I know I saw you. Vicki, are you there?
Good evening, everyone. How's everybody today?
Okay. Absolutely wonderful, Vicki, that we're thrilled again. The person that got the whole academic thing going. Again, we'll talk about that. Linda? Hey, Linda.
Hi, everybody.
We were talking about some things that are going on in the coding world and of the work of the Dental Hygiene Coding Focus Group. I'll talk about in a second. Janet, are you here? Janet Hagerman? Not yet. AJ? Jarbeck, she came to our breakfast, which is great. Jamie Collins. Oh, Jamie, I want to talk to Jamie because I sent her books. It took from February 1st until the 21st, 3 full weeks to get from Chicago to northern Idaho. Who said they live in northern Idaho? Wait, didn't you say that's where you live, Barbie?
Yes, Sandpoint.
Okay. Oh, no, Maureen has severe laryngitis. So Maureen House may not be able to talk to us. I just read that up there. So anyway, Sandy Rago. Sandy, are you here yet?
Yes, I am.
Oh, welcome. Hi, Sandy. Another one of our academic team. We'll talk about that. Susan Volk. Not yet. Susan's from Georgia. I met her when I spoke in Georgia, and she was at our breakfast. Thrilled to have her. Karen. Karen, are you here yet?
Yes, I am.
Hi, Karen. Did you see I put your picture up there? You. Lori Crawford. Not yet. Debbie Z. Oh, say hi,
This
Lucy.
is Lori.
I know I saw.
Lori's here.
Who was that? Lori. Hi, Lori.
Lori Crawford.
Great for you. Thanks for being here. Say hi, Lucy. I saw you here.
Yes, hi. This is my first meeting. I'm a new person.
Terrific. Welcome. Welcome. Mary Gavoni, is she here yet? Not yet. Mary Gavoni was also pivotal in our academic world. We'll bring that forward. Carol, Roselle, are you here yet?
I am here.
Terrific.
Hi, everyone.
And I have your picture on a slide. We'll talk. And of course, Cindy
Okay.
Purdy, you're here, right?
Present.
Hi, Cindy. We're so glad. Kathy Forbes, are you here yet?
Yes, I am.
There she is. There's our Kathy.
Yep.
Are you shuffling papers, Kathy?
I am.
Of course you are. Super paper.
Be prepared.
Barbie Lynn, say hi, Barbie. Everybody.
Hope everybody's having a good day.
Hope you don't get snowed in. Patty B.
I'm here. Hi.
Hi. Nancy Brohan, how's our Nancy doing? Say hi, Nancy. I saw you.
I'm good. Hi. I'm on another call too, but I'm here.
Oh, multitasking.
Multitasking.
Okay, Beth Egan, are you here? Say hi, Beth. Nope, not yet. Jean. Say hi, Jean. Say hi, Jean.
Here.
Thanks, Jean.
Hello, everyone.
Carly. Carly? You here yet? Not yet. Kendra? No, Jeanette?
I'm here. Hello.
Thanks again, Jeanette, for all your help with the breakfast. You were really helpful. Really glad of it. Val, are you here yet? Not yet. Okay, Jill, say hi, Jill.
Hi, everybody.
There we go. Anne Marie. Okay, I know I saw other names, so if I haven't recognized you already, who else do we have here online that I haven't recognized? Okay, who's here as admin? That's Lori Crawford. Okay, I can see that now. Cindy. Alicia,
Hi.
say hi, Alicia.
Hi.
Janet Jordan, say hi, Janet.
Hi.
Hi, Janet. Welcome. I just saw. Okay. Oh, that's Sandy. Okay. Who else do I have? Vicky, are you in twice, or do we have two Vickies?
It's just me. I'm in twice. I was on my computer, but it wasn't cooperating.
It's all good. Okay, and I just saw AJ. So say hi, AJ. Okay, she's here. AJ Jerbeck from Michigan. So at this,
Patty.
hey, girlfriend, thanks again for coming to the breakfast. At this point, our DMC community has 133 members, and this will continue to grow through your assistance. And it's about the one-on-one power. I found this link today. I'm in these different futurist groups that I just thought was so cool. Now, if you can't hear the sound, it doesn't matter, because I'm going to link now to Facebook and show you a video through a Facebook link. But I just thought it was so appropriate for setting up our discussion for tonight. So, Patty, you saw this work before. Let's hope it works now. Can you see it?
Yep.
Yep.
Here we go. Mhm. Amen.
I love that, Pat.
Mhm. And that really defines the work of the dental podologist member group. We are creating the future, not just waiting for the future to happen. Focus on the youth. As much as 1 week ago, a week and a half ago, really sad thing happened down in Florida. Look at the power of those young people. We all have the power to influence the future and our outcomes. Now, I asked you, I sent out a survey monkey to ask you guys, because this is our group, this is our community to define. And one of the things that I asked is, what night of the week is the best? Should we meet on Sunday, Monday, Tuesday, Wednesday? And here's what you said. Yeah, hello. Well, with that definitive answer, we have had our masterminds we had a couple on Wednesday, we did a couple on Tuesday, so next time we'll try Monday, okay? Because obviously there's no one night that's going to be ideal for everybody. Now, these mastermind sessions are recorded, and what I learned to do last month is learn how to put them up on Facebook. What I didn't learn how to do is put them up on a private link. So I will put the link. I will put the recordings up on Facebook, and if somebody happens onto it, oh well. But that way, if somebody, because we tried using the Dropbox, and what happens is these meetings end up taking so much space in people's Dropbox. If they don't end up having a subscription, it fills it up too quickly. So I will send a link for when the video is ready on YouTube, on a private YouTube channel, on our YouTube channel. Okay. Now, we can do a closed group, but help me how to do that, Figgy. The other thing is that I asked you about growing the community. And I set a goal last month to have 200 members by the end of the quarter. The end of the quarter is exactly 32 days from today. So we need 67 more members. So how are we going to get more members? Patty Beeson, would you please talk about, when we were talking this afternoon, I'm going to put you on the spot, Patty.
I hate when you do this.
Cindy does too now. Anyway.
Yeah, and so I have learned.
We'll get back to that. Anyway, can you talk about though? We were discussing this afternoon. We're talking about who we could invite to be members. We are a very hygiene-centric group at this point. But one of the joys that I had at our breakfast at Chicago Midwinter meeting is the very first group that showed up was from the Dental Assistants Association. And that is awesome. We want to bring in dental assistants. We want to bring office managers. We want to bring in dentists. We want to bring anybody that wants to have a say. So that's kind of generic, and I've said that before. But Patty, you were speaking more specifically to it when we were talking this afternoon. Can you share what we were talking about?
I'm here. I was saying not necessarily nice words. Come on, I can hardly remember where I am, let alone what I said. No, that we were talking about, we're not the only ones in this mess, and we need people who have different viewpoints. There are dental assistants, there's office managers, there's receptionists, there's dentists who need to know more about how and why and what we do and how we need to do it, and credible information, not just word of mouth from the guy down the street or that he saw at the meeting or sat with at a luncheon or stuff. We need information. Everybody needs it. So that was kind of my point, that's where we should be looking. It may be our office. It may be an office we temp in. It may be other people that we see at different CEs and stuff. There's a lot of misinformation out there, and we need to get the correct information out, and we need to become really credible sources, and we need more people in there and different points of view, because I love hygienists, but sometimes we kind of think alike.
No.
Yeah, there we go. See, it came back to you, Patty. And that's what I see some of you in the chat box about, saying different things. Somebody, I think, Jeanette, did you just say you have what did you call it? The office manager queen? Jeanette? Okay, not going to say it. Okay. Anyway, moving forward, part of it is that we realize that, go ahead, somebody.
Yes, she is the queen. She is amazing.
Great.
We need her on here.
Yeah, we do. We do. The thing
How
is,
do I do that?
we can also provide some more tools for you for recruitment. Now, we developed quite a few new pieces for the breakfast, and it was just at that time. And one of them is this is the services, or this is the part of the marketing aspect of what an annual membership subscription gives people. And it's great, it's nice and all that. But we also did a video that we were running in the background. It doesn't have sound, and I'm going to talk over it as I play it here for you today. Now, this could be played in a component meeting. It could be played at will. I actually have it online with no sound at this point. There will be sound in the future, but you can see that that is playing twice. I don't know why that's doing that, but that's okay. But it appeals to the no voice encoding and the frustration that we all have and the amount of time that we're spending for not very much value. And that's where the solution when we've come up with is our dental codologist member community. And with that, the easy lines are that it can help boost accuracy as well as increase profitability. But the big thing is the voice in the future. And it's easy to sign up. They just go there, and it's set up with a lot of benefits. Now, the benefits that we have are, ta-da! Here it is, the dental codology membership community and certification, which you're going to learn. But dealing with dental benefits and carriers and codes often leads to that kind of frustration. We've all felt that. Fine on the phone is, confirming the benefits is just such a waste of time, and the answers that you get are like, So there has to be a better way, and that's what we're coming up with here, is creating the better way. As we just saw in the other video, we're creating the future, not just waiting for someone else to figure it out for us, because we can have the voice. We can make our desires known to shape the future of coding and really the whole shape of healthcare. And the way that we can do that is by joining together for that united purpose. Again, I've structured it to be like a Prime membership. There's a lot of benefits. One of them is the e-zine, the multimedia. We put videos in there and video tips, tricks every month. Discount on the different dental codology products. Those are all the mini books. We are now in the process of completing, right, Cindy? Our other two books are going to be full size. These monthly mastermind to have a say, our meetups like we had in Chicago, as well as a service I call pinpoint tutoring. And I'm going to talk about that in a moment. But the really exciting thing is the DCM certification. We've put together an academic advisory board with Vicki, Sandy, Noel Paschke, Karen, some others. And it's about making the certification that's going to be helpful to the practices, the offices, and reducing errors and reducing problems, as well as a certification that increases participants' earning potential. That's the technologist community in a little bit of a brief little 2-minute video. That's what we can do. I can provide you with that video if you'd like, again, with the voiceover, without the voiceover, whatever way works for you. I also have been asked by some speakers and other consultants if they have 5 slides that they can drop into their program. And when they beg me, I go, oh, yes, I do. That's why this one's on a very plain background. As a speaker, one of the things I know is sometimes I get really busy slides on a crazy background. Even though we have a kind of a cool background, I made this on a plain background for speakers. I also include the YouTube link because that video is on YouTube if people want to use that. A second slide that I've created that is important, and this is just another important emphasis as a learning thing, is in order for me to talk about codes as well as to write about codes, I carry 2 licenses from the American Dental Association. See, ADA actually owns the code set. And with that, under fair use doctrine, someone can talk about a few codes, but if you're training on codes or you're writing on codes, you really have to carry these licenses. Now, me hanging around the coding meeting for the last bunch of years, my work was recognized and I was asked to write a chapter in CDT 2017, 2018, and I was just recently invited for 2018. And they asked me for another offer for 2018, 2019, and I recommended Kathy Forbes. So we're hoping, Kathy, I don't know if they've reached out to you yet. But the big thing is this is hygienists and other people getting involved in the process. But it's really important that we can share when we talk about it is when you read something about codes, when you're listening to somebody about codes, are they licensed? Are they licensed to talk about what they're talking about? So those are a couple slides that, again, I can provide. We also have updated our flyer about what the annual membership is all about. But this thing on the left here, this is a real key thing that I created back last year. The D4346 is getting more attention. Oh my gosh, it's absolutely crazy how interested people are because it's something we've known we needed for a long time. Yet now that we have it, many of us don't know what to do with it with this new code. So I created, now that's the size of a credit card and it's plastic. And what that means is there's one side that mentions the gingivitis book. The other is what I call the 8 focus points for the 4346. All of these can be, I give these away at all my courses. And if you want them and you want to get some for yourself, I have this link. So you can go right to the dental codologist website. They're free. Okay. And order. I mean, I've had people order them 3, 50, 30. Well, we had that one hygiene school that ordered 100 of them. And that's great because they're safe, they're treatment room safe, but it also gets the message of dental codology out there. So if anybody wants any of these materials, again, the cards you can get online. I'll get the rest of the stuff online eventually, but just ask me for it, and I'll send you whatever it is you need because you need the tools to be able to talk about it, but specifically ask for membership. Not just tell them about it, but ask, say, invite people, because one-on-one invitation is what works the best. Now, I've alluded to the dental hygiene co-focus group a few times here, but for people that are newer, let me explain what that is. About 15 months ago, I was asked if I could bring a few friends to the codes meeting. See, the codes meeting, the code maintenance committee meets every year in March, and anybody can submit a code, and then there's this committee that decides on who gets the codes or not. Well, dental hygiene does not have a seat at that table. We did investigate what it would take to get a seat at that table. And when ADHA, Hygiene Association, asked the codes committee, their first response was, nobody ever asked before. We don't have a process. Well, isn't that interesting? So we officially asked from ADHA to the codes committee, said that we want to be on the committee. After about 6-7 months, they decided no. If they let us on, then everybody's going to want to be on. Yeah, because there's such a groundswell. Anyway, so what happened is because there is an aspect that many hygienists have ever shown up or participated much with the codes committee that we put together. Well, I was going to bring a few friends. Well, that few friends turned into, at one time we had 134 members of our dental hygiene coding focus group. That focus group has been amazing. The number of times we've met and the work that we've done. We're very proud to say that 6 of the 66 submissions that will be heard at the Code Maintenance Committee here in 2 weeks were submitted by the Dental Hygiene Coding Focus Group. We did it together. Some of you on this call have been on that committee. Some of you haven't. That's why I'm explaining it. Because what's also happening, because we've created dental codologist membership, is it's morphing. See, the dental hygiene coding focus group will end the couple of days after the codes committee ends. It meets, and the reason for that is I can't manage it all. So the dental hygiene coding focus group has become the global dental codologist member coding focus group. And the reason is that because we still need a specific group of people that choose to be involved in actually helping create the codes. Our dental hygiene code, again, the one committee ends on the 18th, the first meeting. When we did the survey with that group of what days worked, we found out that Sunday evenings are the best for that group. We will continue our meetings on Sundays for the coding focus group, and the next one will be on Sunday, the 29th of April. The reason is that inasmuch as the codes for 2019 will be decided on March 15th of 18, we'll start working on the codes for 2020 in April. Did that just confuse you? Yeah. It's a much farther ahead process of thinking than a lot of times we've been used to. So what happens is between now and November 1st of this year, anyone can submit a code or submit something that they want to see as a change or an addition to the code set. You can have till November 1st of the preceding year. Then the following March, the code committee meets and they determined what will be changed, passed, revised, or whatever for the following year. So the codes meeting that's happening on March 15th will decide the codes that will go into the book or be changed for 2019. Okay, so that's the process. So that's why we need to start meeting right away, because this process of submitting codes is a very important process that takes some time and it takes some thinking. And we get a better product when we spend the time and not rush it at the end. Now, I'm coming up to, let's get into the discussion that we're going to have between us. That was the beginning part. With the new service that I offer now with Pinpoint Tutoring, I had a consultant, hygienist consultant, that called me, and she was presenting to a group. And so one of the things we talked about was how much she could present and not present based on the fact that she doesn't have a license to discuss codes, but she can, under fair use, you can talk a little bit. And one of the things she asked me is, what's the code for full mouth disinfection before periotherapy after the evaluation has been done? And I'm going, first, huh? Now, what this gets into, and this is why this is the introduction to what Cindy's going to bring us forward to discuss for the rest of our time together, is this is as much a philosophy and periodontal philosophy question, because at first I didn't even get it. So she explained that, well, the comprehensive evaluation has already been done. There has been a diagnosis of active periodontal disease that needs therapy. And what she teaches and what she was taught by JP Consulting and some other consulting groups is that you do a full mouth disinfection. In other words, kind of swing around the whole mouth with an ultrasonic as a way of disinfection to reduce the bacteremias before they have their actual periotherapy procedure. And what's the code for that? She had been told previously D1110 prophylaxis code is appropriate. But should it be the D4355, or really is it a D4999? Kathy Forbes, don't jump out of your skin.
I'm biting a hole in my tongue.
You are. You are.
Alicia, say it.
The thing is that what's interesting about this is Again, it's a combination of, it's a coding question, but it's a philosophy question. And it also brings us to really where we want to go tonight, and that's to Cindy Purdy. Cindy Purdy has become a dear friend, although she may not say that about me, because you tell me, okay, fine, Cindy, you can tell them the story about how this evolved. By the way, Cindy, that's from our book. You haven't changed your introduction, so I used our introduction out of our book. But Cindy, why don't you tell them a little bit about yourself, and then tell them about your connection with Dental Works and Crown Seating, and then we'll go into the purpose of our mastermind tonight.
Patty, I might need you to take over for just a second because I'm having a coughing fit.
Okay. Cindy Purdy, RDHBS, has 37 years of clinical dental hygiene experience and a passion for advancing her profession. We can all read that. Anyway, Cindy has been the president of the New Mexico Dental Hygiene Association. She moved from one of the highest leading edge cosmetic practices in Albuquerque to a very different environment where she works now, where she still practices clinically now. But in addition to her clinical practice, she also has been working with Crown Seating and Dental Works for some time. You ready?
I'm going to try.
Okay.
I went to Chicago midwinter and got my traditional trade show cold.
Mhm.
So I'm having coughing fits all day, so I'm going to try. I'm working. I live in a tiny little town in Colorado. Some of y'all may have heard this story. There's only 1,000 people here. I thought I was the only dental professional in the whole county. I have found out that there is one other hygienist here, but she practices outside of the county. And I had one dentist that was here who came in and out from Florida who would see patients, and we were working about 6 to 8 days a month. Pardon me. And he had to retire due to musculoskeletal disorders, which is interesting since I lecture on ergonomics. But he had to sell the practice. We couldn't get anyone to buy it. So for 2 years, we had no doctor here. And now I have gotten another doctor to take over the practice, and I actually work with teledentistry to transmit my information to the doctor who's like an hour and a half away. But what happened when I first started working, you know, like Patty said, I went from a very high-end practice in New Mexico and moved to this rural area that is nothing but ranchers. And the main topic of conversation is hay. Did you get your hay put up? Who's working for you to put your hay up? Did you get it out of the rain? I mean, that's the big discussion here in my little town. And everybody has 3 jobs. Nobody has, very little dental insurance coverage here. The city government does, and the few educators that we have, teachers have it. So it's a very different viewpoint and different concept from where I had come. Sorry, I'm trying to not cough. So I, in confidence, was sharing a story with Patty of my conflict on a particular patient. It was 2 patients, actually, a family. When I first came, the doctor had been seeing a lot of his own hygiene patients. So we shared a lot of patients. So he had the young couple in their 30s, Amish family, young Amish couple. The doctor saw the husband, I saw the wife. We both went through the medical history form with them. We both took x-rays. And I started doing my periodontal charting. And from the other room, I hear, he's already started the ultrasonic. I haven't even finished charting. I haven't even discussed her periodontal condition because neither one of them had ever been to the dentist before. So we had a lot to talk about. And of course, I knew my role was education, right? So told her she needed 4 quadrants of scale and root plane, periodontal therapy, told her why she needed it, explained the whole program. And in the meantime, in the background, all I hear is the doctor in the other room blasting away at the husband. And they're laughing and talking. And after I had explained what needed to be done and the cost, because I've always been taught not to look into their pocket. You diagnose according to the disease that's in front of you. The woman starts crying. And I'm thinking, and I hadn't been working there, but maybe 5. We'd only been working together maybe 5 different times. So I thought, great, this is going to give a great impression to my new doctor. And I asked her why she was crying, and she said this was the only time she had ever been to the dentist, and the only time she was ever going to be allowed to come to the dentist. Excuse me. So this is our tough choices. You know, I thought I knew what I was supposed to be doing. In fact, as she's crying, her husband gets finished and walks out of the chair and jokingly walks past her and says, "Aren't you done yet?" You know, like, I'm in and out already and I've been treated. And I started realizing, I mean, I've had people, when I've told this story, I've had people say, well, I would have just asked her what she was there for and what she wanted. Well, if she had, in my mind, if she had never been to the dentist, she wouldn't even know what to ask for. I mean, think back to the first time you've ever gone to the gynecologist. You don't walk in and go, "Hey, I want to put my feet in those cold stirrups and scoot on down to the end of this table." I mean, you don't know what to ask, right? So she didn't know what to ask. She just came and presented herself. She didn't even realize that there would be a possibility that she would have to come back multiple times. So I quickly surmised the situation and thought, this is not going to turn out well. So I pulled out my ultrasonic and started blasting away, because I thought, this is the only way she's going to get any type of treatment today. And when we go out there to compare the two, we're going to pay virtually the same thing. And no, I was just totally confused as to who actually got the best treatment that day. And I went home still totally confused, not really knowing, you know, did I serve the needs of my current population, or was I just doing what I was taught in my high-end office? And of course, everybody gets scale and root plane if they have 5mm pockets, and you know, you can't even see the bridge of, there's a bridge of calculus and you can't see the teeth. So these are the type of people that I see. And I still don't know, because I still don't even know what code I should have put that under. It's exactly what Patty was just talking about. So I am in the area where all of the patients we do CYA with our patients and tell them, if you don't get that 4 quads of scale and root plane done, we're not going to see you in this office. No, you can't come back and just get a debridement. No, you can't have a cleaning. You need 4 quads of scale and root plane. And if you don't agree with our beliefs, then go away. Well, guess what? I'm in the area where all those people go, and I have no one to refer to. So for the last 5 years, I'm sitting here trying to figure out what to do with all those people, because they're not getting treatment. They're all telling me, well, 10 years ago, 8 years ago, I was told I need to have scale and root plane. I couldn't afford it, so I haven't done anything, so here I sit. Well, what am I going to push them away for another 6 or 8 years ago? If I don't help them, where are they going to go?
You would be abandoning them to nothing.
But they're working 3 jobs. I mean, these are not people, a whole different environment than I've ever seen before. So, again, it's how do you make the tough choices and how are you going to code them? So I ended up, I know the instruments that I have. I know what they can do in my hands. And I would ask them, I'd tell them they need the 4 quads of scale and root plane. Yes, they were correct. If you needed it 6 or 8 years ago, you could definitely need it today. But if you can't do that, instead of me kicking you out of here, would you be willing to come in for an hour every 6 weeks, 4 to 6 weeks for the next 8 to 9 months? Well, sure, I can budget for that. I can do it that way. And I ended up treating multiple patients like this. And my doctor didn't care. My doctor, such a small town, he just wants to be able to walk down Main Street and wave to everybody and know that he's giving them good treatment. I asked him, what do I code this at? He said, I don't care. They don't. And I realized these aren't insurance codes, but, you know, he said, we don't have to worry about that. Just treat the patients and get them into health, Cindy. I'm so sorry. So that's what I did. And lo and behold, by the end of 8, 10, 12 months, they were just as healthy as if I had done the scale and root plane at that time. And I realized, you know, I go to the AOSH meetings, I understand all the oral systemic, but here's the tough choice. Should I let them walk out the door and know that that's really going to affect their oral systemic condition? Or should I try to, I mean, I'd much rather have them get it all done, but what's the right answer? Again, I just keep going back to what's the right answer and how do I code that procedure?
Okay, and let me take over for you, Cindy. Thank you so much, and thank you for stressing your voice that way. Let's go back and think about it through that question that someone asked. Was it a philosophy question? Was it a coding question? Is there a code that's needed, or what is needed about coding? Because coding, of course, they're not insurance codes. They are procedure codes. That's all we have at this point. So let's open this up to discussion, because I already see some things flying over there in the comments. But this is it can sound like at first that it's Cindy and her community, but it's not. So let's talk. Let's talk about this among ourselves, about what we need, how we think of this. Because the thing is that Cindy really told me this in confidence. She says, I'm almost embarrassed. I'm like, why? This is exactly what we need to talk about, because this is the difference between here's the ideal world, here's what we know, but now we're sitting knee to knee with this patient. So somebody start talking.
Patty, can I talk? This is Vicki.
Absolutely, Vicki. Go for it, Vicki. Hello, Vicki?
Can you hear me?
No, we didn't hear you. You said we heard.
Okay. I'm sorry. Can you hear me now?
Yeah, we can hear you now.
Okay. I'm going to talk about being in Trenton, New Jersey, which is one of the lower income parts of New Jersey. We're in the Northeast, and, you know, we're pretty progressive here. But we have, and I was never prepared for this as a hygienist. So, Cindy, I can so understand that. I would have patients come in and say they couldn't afford scaling and root planing. And in my heart of hearts, I could never let them go without doing something. So, like you, Cindy, I went in and grabbed my Cavitron and did what I could, you know, saying I'm doing the best I can, but please realize that this isn't the cure-all, end-all for what you have, but I want something better for you. I don't want you to go along with your disease process. So I want you to understand, and everyone here, you know, here in the Northeast, we're pretty progressive, but we're still dealing with those issues.
Thank you, Vicki. Patty, you did that. You had the same thing up in North Chicago, didn't you?
Yeah, we did. We were a PPO practice for a while. We had well, anyway, we had a lot of people who they didn't have insurance or they didn't have money. And if you abandon them completely and say, too bad, I'm sorry, this is what we do, if you don't go along with this, I feel like you're abandoning them completely. And we had some people who, you know, probably should have ended up, we used to see patients out of the VA system, they're drug and alcohol rehab patients. After they'd reached a certain point, they could have some dental work done. Well, the VA couldn't handle it. So we had a contract with them, and we would see these people. And we would, yes, it was scaling and root planing, but oh my God, on such a huge scale. And they might not have much bone. And you would ideally treatment plan, you know, we're going to extract these, but we would give them a chance. We'd go ahead, we'd get in there, we'd debride, we'd scale, oh my God, we worked. And a lot of them came out as well as you could expect. I mean, really optimal. Should we not have done it that way? Should we have done it? I don't know, but we gave them a chance. A lot of them were motivated and they took care of their mouths and they understood. I don't know. Periodontist might not have liked it, but we got a lot done.
We have Lisa Graziana and as well as Sherry Lukes here, and Linda Jorgensen too. You've all been educators. What would you tell your students?
This is Linda. One of the first things that occurred to me is all of you were, I've been a dental hygienist for 49 years, and I've seen all of the things that you're talking about, and I'm pretty sure that I gave away a whole lot of perio. I called it 1110. I think that was the expectation. Until I could use local anesthetic, I did everything without it. I'm sure I hurt my patients. I aggravated them. They hated me. But damn, they got better. I mean, I know that they got a lot better. Anyway, so here's the way I would sort of frame this whole discussion. There's good, there's better, and there's best. And sometimes your patient will only accept that lowest level. They'll say, I got to be out of here. Like, do what you can. This is my only opportunity to have you work on me. So do what you can. And I think, because I want to do the best, obviously, and my employer wants me to do the best and charge the most, that's because it's a business. I got to make some money. But maybe the only thing that the patient will accept is something that's just good. And it was good. Everything that we do for our patients is good, or it should be at least good. I don't think so. I mean, if we can talk about it and think about it that way, as far as coding goes, if I can present the best, and then the patient goes, I don't know if I can afford that. I don't have time for that. I don't have insurance. I can't figure that out. How to approach it that way. What are my other options besides that best thing? So, and honestly, I'm very flexible when it comes to treatment plans for perio, particularly for perio. And, I think I probably, I think about the amount of time that I spend and the materials that I use and the instruments that I use. And I try to code now, especially now, I would code accordingly. Depending on, and like you said, Patty, time and again, the diagnosis is the same and the treatment will depend on the diagnosis, and then the code depends on the treatment. So,
and the metrics that those codes represent, again, whether there's benefits or not, is not the most important thing. Here's the thing, though, about codes, even and metrics at this point. Right now, the only place that metrics are being counted, unless we're in a DSO or a different type of a corporate practice like Maureen is within in carriers themselves, because no other metrics get reported. I mean, because like Cindy's practice, if they don't have benefits, it's not going anywhere. That doesn't mean that it won't, because they will eventually, as we move farther into the electronic health world. And that's really what a lot of my work is about, is preparing us and forging that future of the electronic health world and the potential that we have with it. And it is all potential, because medicine's farther along than dentistry is. But boy, I keep hitting myself in the face with that, where that's at. We have lots of work to go. But that's, again, about not just waiting for the future to happen, but forging the future. Again, let's get a couple more of the educators in there, and then I'm going to ask a couple of other of you. So Karen Siebert, again, you've been an educator. Lisa, Jerry?
Well, I can say from my point of view is it's unfortunate as a dentistry in whole, we kind of treat to the financial status, right? We treat to the insurance, we treat to the what the patients can afford. So what I'm teaching my students is, oh my gosh, this is such a clouded thing. I'm teaching them to treat the patient as a whole. You treat their disease, or diagnose their disease, treatment plan their disease, and diagnosis as best as you can and move forward from there. So once that happens, you need to think about it as far as the best need for the patient. We know it is the best, but can they afford it? Do they have insurance? And it's unfortunate that the mindset across the general mindset is that, you know, there's a lack of dental, you all know, there's a lack of education across the board in oral health. So trying to get that across to get that across to your patients, just like what they really need, how it needs to be treated to get them out of a disease state. That's kind of where I go from, is like, don't think about the money and the insurance when you're making the diagnosis and you're doing the OHI and what you want to treat. And then you have to, once that's established, once it's said, like, I don't have the insurance, I can't afford this. As long as you're doing your job and educating your patient, knowing what their needs are and what the outcome's going to be, you can kind of take a little bit at a time, like, well, we can do this time, we can do this time. This is our ultimate goal. That's kind of what I'm teaching them right now. And funny enough, I also teach them ethics. I'm their ethics teacher. So there's days where I'm fighting myself in my head, like, okay, do the best that we can. This is ethics. We need to do this. We need to do that. And it's really, it's frustrating and exhausting trying to make the right decisions and teach them the best, you know, to put their best foot forward and do what they need to do for the whole patient.
For
so
sure.
That's kind of what I'm doing.
Thank you. You brought up exactly the whole challenge that we have here, the balance of ethics and what we know and what we believe. But again, the person needed E. Alicia, you had a comment, you had a question?
Hi, Patty, yes. So I basically, I was just thinking, I've been in private practice for like 15 years and I'm just started educating about 6 months ago. So from what I've noticed is a couple of these students are assisting and they're asking, sorry, I started making notes because I was thinking here. So they're asking, they're asking about like dental associates, for instance, like when there's like a standardized way that they treat their patients that are new patient, FMX, that like they follow a protocol, formulary pockets, etc. But what I've also realized with them is that they're asking about coding and finances, and like there's no room for that. They don't learn that in school, and how do you really figure that in? Since we're talking about coding and then schools and education, it just started to make me think of that.
For sure,
It's much bigger than just a debridement, you know, or whatever they're calling it now.
Well, it's not.
And the other thing, I'm sorry, I had one more thing. The other thing, I just wanted to comment who was talking last. Like, as somebody who's extremely empathetic, I hate saying this, but as somebody who's been in private practice for a long time in different offices and not just one, you start to see the patients who can afford things, they can do things, and then you're the empathetic hygienist every 6 months educating and educating. You know you're doing your job because it's not somebody you just take after. Like, there's got to be some place where we end with the empathy and balance, like you were talking about.
Carol Roselle, you had another comment?
Yeah, you know, first of all, I've been a hygienist. I was clinical from the dark ages of, you know, in the 80s. And I originally started out working in an office that took in a lot of immigrants, Polish people that came in to better themselves and then went back into Poland. They did not have the dental knowledge that we did. There was a lot of perio, and Cindy, I certainly can sympathize with you. We had a lot of situations that I could say, you know, 4 quads, let's get it going. But what if they were coming back, and if I was able to educate them, I was doing them a service. And we have to take the situation for right now where it is. If we can treat them on their finances the way you are doing, and the way, and educating them along the way, not only are you making them better in the long run, but you're also teaching them the value of the quality care that you are providing them. And who is to say that they don't win the lottery, marry someone else, get a different job that gets them dental insurance, and they will know the value of what that is. As important as it is in our educated world to follow the metrics and follow all this stuff, there is a whole other world that it's just that day-to-day getting by. And I think we're doing a greater service by elevating their dental IQ, as it's called, and educating them along the way and kind of holding their hands. Like you said, she had no idea what to expect. So how could you expect her to value, even if she could come back for more, how could we expect her to value the necessity of those 4 quads of scaling and elevating her oral health when she had nothing to compare it to? So
Absolutely.
I think you're doing the best service imaginable by elevating their education and catching them up with the rest of us. So my hat goes off to you, Cindy. I think you're doing what you're supposed to be doing.
Cindy, this is Kathy Forbes. I want to share a quick story. I was in a practice where one of my patients was a darling little Vietnamese woman. She was coming in, and I was told that she needed root planing, but she couldn't afford it. That was all I was told. And when she sat down, found out she was working 2 to 3 jobs to put her son through college. She knew she had periodontal disease. She knew that she needed something to do, but she couldn't do anything till he was graduated. She understood what was going on. And I was told, do supragingival cleaning, bill it out as an adult prophy because there was no insurance involved. And she came in every 4 months, and we did that. And we did that for about 3 years. And she came in this one time and she had this big smile on her face. And she said, guess what? My son has graduated. He's working for a company, has his own dental insurance. I'm ready to do the scaling and root planing. So, yes, she understood all along that she was losing a little ground every time. But for those 3 years, she was diligent at least to get in and do something. And I think sometimes we don't give our patients enough credit that if we educate them along the way, there might be that turnkey where it clicks and they can financially afford it or they understand it or whatever. So as a lot of coming through the chat box, it's education. It's education.
Jean, and that's what you said too. Sometimes patients surprise us and accept treatment in some form when they're well informed. I think we all believe in that. So, how many of you are using the D9950 Behavior Management by Report Code? Have you ever heard of it before? Probably not. Now, that's a code that is different in that it is actually much more along the medical lines, in that it is a time-based thing. It is a 15-minute increment code. In other words, you are spending 15 minutes specifically on talking with them about changing their behavior. Now, from a coding perspective, how important yes, Jeanette, like Canada, because Canada has much more of a time-based coding system. And that's what I want to bring this back around to, is the idea of how codes can help us, frame our thinking, but how we also need to use codes that are there. There's probably more codes there that we have that we aren't using now, but they're also, I think what we identify here is perhaps a different way to consider looking forward at coding. Not just looking at what we have and how we can fix it, but really thinking through what it could be ideally. One of the things that I experienced at the CDS Midwinter meeting this week is that I'm invited to be part of the ADA Informatics as well as Snowdent group. I'm happy to say that I was not found in a ditch dead because I brought Patty Beese into that meeting and she thought it was the most boring thing in her whole life. But anyway, she won't kill me dead for that meeting. But what was interesting about it is something that I was told by somebody that has attended that meeting. And apparently there's a great deal of disdain by the Standards and Informatics group to the CDT process, to the current way coding is done. And the opinion has been shared that the people that really get into standards believe that the CDT process is nothing more than opinions and politics. Now,
surprise, surprise.
Surprise, surprise.
That was, by the way,
I've been involved in it.
That was the only interesting thing that happened.
What?
That was the only interesting thing.
Come on, we discussed it, and 16 or 17 angels dance on the head of a pin.
Yeah, that was what the discussions were like. Oh my God.
It was very detailed. I'm really glad somebody likes to do that stuff. But the thing is that, okay, that's an understanding that we have. If that's the case, then let's play the discussion we just had through that filter. Should there be a code for what we're describing here? For whether it's that person with the pinpoint that her philosophy is to do a full mouth disinfection, even though I might question the scientific basis of that, or what we're talking here, which again, we can question the scientific basis of. So where does this lie? Any thoughts on that?
It seems like, especially when we're talking about scaling and replacing, it's going to be about, let's say, 4 to 5 hours of operator time. But what we're going to do is we're going to divide it up into smaller increments and charge it over a much, much longer period of time. I mean, that's the way I viewed it at the time. If I needed to do that, because that's all the patient would accept from me, like those appointments, instead of being scheduled 2 weeks apart, they were scheduled 3 months apart, 3 or 4 months apart. I have done that. I viewed each one of the appointments was one part of the total case of scaling and replaning. So, I mean, I kind of view it, we're still doing the procedure, we're just the timing of it, the intervals between visits is what's different. And does that be coded differently?
There's precedent with the behavior management 9220 in increments, that maybe some kind of code for just an increment of time to do scaling and replanning or whatever could be, considered for CDT 2020.
Well, first of all, one of the things, if we're going to put something in, we're certainly not going to call it scaling and replaning.
No, not at all.
Are we? That is such an old term that's stuck in the 50s and 60s. That's one of the challenges that we have, is because so much of the thinking is stuck in the 50s and 60s, as if calculus is the biggest problem. I'm certainly not saying leave the calculus. Please don't hear me say that. But
it might pass better if it's not called a scaling and root planing, if we come up with something really cool.
Yes. Yes. So Jeanette, please say what you're writing. Can you say those out loud? Go, Jeanette. Go for it. Come on, say it out loud.
Okay. Well, a lot of the laser hygienists that I've talked to just lump it all together under periodontal therapy. So, and that just includes the debridement and any other adjunct you would use with that, whether it's lasers, whether it's Arrestin, and I think that's a all-encompassing broad term that you can use. Is just periodontal therapy, because we're treating the periodontal situation.
And that's from a languaging point of view, I think that's a good communication. But would it give us the metric that we want? Because one of the codes two of the codes that we have submitted from our dental hygiene focus group is, okay, Jill, you say it better because it's your code. How we do that? Light induced, what is it? Jill?
Light energy.
Okay.
Application of light energy for management and maintenance of acute and chronic inflammation and pain to facilitate healing.
Okay, explain a little bit about the why that we didn't use laser language yet. Basically, that's what we're talking about here.
Yes, because we are talking laser, that is for sure, but the laser encompasses many different applications and many different lasers. So it's a general therapy, that type of thing. So that's why we use that to broaden what we're doing with it. Not just periodontal therapy, but there's other therapy as well. It's basically for the not only the prevention, but the maintenance and the the healing aspect of it.
Mm-hmm.
Does that make sense?
That makes sense. And anything, and the word laser gets mentioned at the codes committee, it's gone.
Gone.
It's gone.
If anything is said with that, it's gone, and they'll jump all over it.
Yes.
You know, as far as it goes, they'll say, where's your this, that, the other thing, and so they'll jump all over it. And that's what has been said in the past so many times. So you keep on saying the same thing. You're going to the old saying, you keep on doing the same thing, you're going to keep on getting the same thing. So this is why there was a different approach to that.
Yeah, and that's why Jill and I have come up with the talking points that discuss what we're going to be using this device for, but don't name the device as a laser.
Right. Because if you say it's specifically a laser, the other aspect of it, that is how you get to somewhere, not a unique procedure. And the codes we have are procedure codes. That's all we have at this point. Now, going back to, again, updating all of you on the Snowdent committee. Snowdent is actually a branch of the informatics, and whether or not that's ever going to be adopted or where that's going is, after having sat in that meeting for 3+ hours or 3 years, is what it felt like. It's kind of where it's going. But one way or the other, diagnostic coding, and the more we start thinking in diagnosis, the more we start, again, using the dental hygiene process of care that we might not have all learned. I mean, if you went to school before, 1989, you did probably learn it as part of your educational process. But the dental hygiene process of care is what we can and should continually go back to figure out how to make these things fit. Now, going back to this discussion of tonight that Cindy brought forward, and as we're talking, can you see a unique code for what we're talking about? Is that something that would be of interest to explore?
Patty, this is Cindy. Because I couldn't talk, I probably didn't finish explaining. My whole purpose for picking up that ultrasonic was not to catch up to what the doctor had done, but I used it to continue educating her. So as I was scaling off, because she did not know the difference between clean and dirty, healthy and diseased, as I was scaling it off, I'm telling her, feel that with your tongue. Do you feel what I took off? Do you feel how the tissue is rolled? Next week, I want you to feel how that's not going to be rolled. It's going to heal up somewhat for you. So I was trying to get her to feel and to understand what health she could have. So maybe if a code was approached, that it was a procedure that was done for education.
Excellent, excellent. Yeah, I agree. Okay, I'm looking in the chat box. Okay, so we have some chat going on here. By the way, the chat boxes, this is actually part of the record keeping for this, for the meeting too. Karen, what'd you say there? Charging people by time? Say it out loud.
Yeah, I was just thinking as everybody's typing in, really this idea of time period and naming it periotherapy really brings home that whole idea of using the dental hygiene process of care and customizing what we're doing for the patient in that time period. So one patient may need laser therapy, another patient may need that periodebridement, and that's all they can have. But that's something that we can customize to what they can afford or what is best for them, whatever we're able to accomplish. And especially, it should allow us to get to a higher level of care for that patient with that customization.
And see, that's the purpose of this think tank. That's the purpose of the dental hygiene, of our dental podologist membership here, is to bring forward these kind of ideas, not just of how we tweak where we are now, but what if we could take it and erase it all and start again? What would that look like? Because that's the power that we have to make changes. And again, to forge the future, not just react to the future that somebody else figures out for us. Anybody have any more comments, any more thoughts? A mastermind isn't to come up with solutions, it's to learn from each other. And I think we're getting better at it. The first couple of these, it was a Patty do all the talking. Now we're getting it to all of us talking. Oop, we got a new voice here. Come on, Lucy, say whatever you just wrote.
Hi, I was just comparing it to physical therapy. I've gone many times for physical therapy, and they might do a different type of treatment at a different point depending what my problem is, but it all encompasses that physical therapy appointment.
Expand it a little more. That's brilliant, Lucy. What you're saying is really.
I've gone in for appointments where I might have had some ultrasound or some TENS treatment, and I'm not usually charged separately for that treatment. It might be a heat therapy, but it's just part of whatever the need is on that day for that problem I'm having.
So to look at it, and again, look at it from a point of view, dentistry, because dentistry is based on the word dent, teeth, and we've turned it into a commodity. And the commodity, it doesn't even count. That's why I think that we have such an absence in our diagnostic codes and in that whole aspect of treatment planning. We don't have any codes for any of those things. Why? I think we don't value it because unless we're actually doing a commodity, and the commodification of dentistry is where these problems come in. And what you're talking about, or what are you saying, is we're looking, what is the treatment should be to the problem, to the diagnosis, and it's not just a commodity. It's not just this equals this. It's broader than that. Somebody else said is maybe we should talk to the Canadian hygienists. Right, Jeanette, I agree with you. I mean, we can there's so much we can learn from other parts of the world that are doing things, that sometimes we fall into the arrogance, and I'm going to say it just point blank the way I see it, of thinking that we know the best. We don't. There's other parts of the world, and partly because of their payment system, they look at things differently. I met with some Australians over at CDS, and I was talking specifically about that. A lot of the way our payment system has traditionally been on our disease-based way of looking at things. We really are, if it ain't broke, don't fix it. And if it's got to be really broke before we recognize it. And the sicker someone is, the more we get paid. Is that a healthcare system? Wherever somebody comes from, I don't think that we can call that healthcare. That's disease care. Carol, what are you saying there? The education we're giving is a commodity.
Yeah, we need to realize that the education that we are giving is, there's value in it, and we can't dismiss that. I mean, maybe it's not tangible as far as, we put a filling in or we've gotten a mouth guard, but we are educating them, and there is a value to it because they're taking that and taking control of their health. So it's really important to continue to realize how important that is as well. And it's prevention. It's
Carol,
preventing.
That really does lead us toward, let's talk about what our next program is, because I did some pot stirring, some big time pot stirring. It's National Children's Dental Health Month. And I was asked by Dentistry Today on their blog if I would write something on it. And I'm going, really? And what I wrote, and by the way, I'm going to suggest that you go over there because it's pretty spicy, and I can't believe they actually published it the way it is. But what I questioned is the whole idea of what National Children's Dental Health Month is. It started in 1941. It's the 77th year of that campaign. And here is the slogan. All righty, hold on to your hats, because here's the slogan. Brush your teeth with fluoride toothpaste and clean in between your teeth for a healthy smile. Really?
That's it.
That's it?
Are you dazzled? And what I talked
after
about,
70 years, that's the best we could come up with.
Yeah, exactly. And I talked about, where our statistics are, where we are. It's like we've gotten as far as we can with that same old tired message. There is, and you may or may not be familiar with, there's a pH app. It's an app that people can download free on their phone. You get them some pH paper, or they can get their own. pH paper is pretty cheap. They spit on it. Phone reads their pH. You tell them to give them a piece of xylitol gum. Tell them to do it again, and it'll read their pH. That's how you make behavior change. At the time, in a way, with technology that they can understand. Now, not everybody has a cell phone. Oh, yeah, the stats on that. The statistics are, and I have it right here in the article, that there are something like 6.8 billion people on the planet. 5.1 billion have a cell phone. Only 4.2 billion have a toothbrush.
Oh.
Okay, so this is about different thinking. By the way, I also said in that article, the toothpaste companies and the toothbrush companies that have the cozy relationships, perhaps, they'll still get more business if we think differently. It's not that we're not talking, we don't need to brush our teeth and clean in between, but let's move our message up, which really comes to what we're going to talk about next month, which is, again, and this is Carol Lettuce there, mark this down, March on Monday. We're going to move to a Monday next month to keep those, because you said Sunday, Monday, Tuesday, or Wednesday are all equal. And Carol, we're going to create a message. Talk about the direction you want to help us take us next month.
Well, with the idea that I work with a lot of seniors and a lot of intellectually and developmentally disabled people, we're always in search of support from corporations and 501c3s. And the problem that we are having is that everybody wants to do everything for the children. I love children. I have a grandchild. I love her dearly. There's no way that I would do anything to stop anything for their development, but we have a bigger problem going on. We've got an aging population. We have so many people that are on medication that cause dry mouth. With the dry mouth, the increase in dental decay is going up. We've got the periodontal problem. 75% of people have some sort of a gum inflammation. The CDC says that the number of seniors with decay has surpassed that with children, and yet to get all that we care about is children's dental health. How do we stress and how do we change the talking points and the philosophy that it's just about preventing decay? It's not. It's looking at it and trying to get that message that we're taking charge of our health.
And you know what Janet Jordan just put in the chat box? How do we get articles into AARP? Yeah, that's the kind of thinking, Janet. That's what we're talking about here, is we need to expand. Because I talk about change and because I talk about what can be, sometimes people think that I'm not satisfied or think we haven't done a good job. We've done an amazing job, but it's not time to stop because we have not solved dental disease. Now, the internalization that we believe that we can, again, those of you that know me, here I go again. Here's the Patty thing. I believe we can cure, not just manage periodontal disease. I believe that we can have a world with no oral cancer. I believe that we can meet the 2020 goal of a caries-free world of the World Federation of Dentistry. Caries-free world, we only have 1 year and 9 months left. We best get on it. We're not going to do it by doing things how we always have. And even when we talked about education here, we talked about debridement here in a different way. All of those things are good points and good conversation. How are we going to do it differently to get different outcomes? Again, we're creating the future. That's the purpose of this group. That's the purpose of us being here together. We are stronger together because of it. And I'm honored that each of you have chosen to spend your time this evening with us. The direct to consumers education, what are you saying there, Karen? Direct to consumers education is an excellent idea. Write it, send it, they'll probably love it. Here's one of the things that I know. Even with one of the our trade magazines, I was offered a place that we can write and we can have as our own to write as many articles as we want, and they will help get it out there. Now, the thing is that we get it into the publications and we spin it farther with our social media. There's ways that we can remember the last thing on that opening video is let's watch the kids, watch the youth. That's the future. Let's do it ourselves. We all have ideas. We all have thoughts. Let's get it published. Let's get it out there. We're stronger together. Again, thank all of you for your time and our efforts together. Again, if there's any of the materials that I can give you to help, 67, guys, we have 67 more members that we want to get by the end of March. By the way, we'll take 167. We'll take more. But if there's anything I can do to help any of you guys, you know how to find me. Thank you again for tonight. Thank you especially for Cindy and her and bringing her story forward. And it really helped all of us. So I wish you all a good night. And again, I'll send you the link when the YouTube video is up for this.
Great. Thank you, Patty.
Thank you.
Good night.
Night.
Good night.